Hello, everyone. Welcome to the endocrine seminar for this week. And it's my absolute pleasure to introduce Dr. Dawn Castor, who is an associate professor of medicine in the Division of Nephrology. Dr. Castor is a graduate of UofL School of Medicine, where she earned her MD, and then she completed a residency in internal medicine and was chief medical resident. She then did a clinical nephrology fellowship and followed by a research fellowship, and she was promoted to associate professor in 2022. She's currently co-director of nephrology research. She's director of the Glomerular Disease Clinic. She's involved in numerous clinical trials, and I think the work that she's going to talk about today is associated with some of that clinical trial work with which she's involved. She's currently PI on an NIH R01 grant, ABIN1 dysfunction in lupus nephritis. She has received a number of awards for her research. She is a peer reviewer for a number of journals, and she has, at what I could count, was 43 peer-reviewed publications. She had a recent first author paper on the treatment of primary IgA nephrology in American Journal of Kidney Disease in February 2024, and a paper on increased urine excretion of neutrophil granule cargo in active proliferative lupus nephritis in Kidney 360 in July 2024. And so I very much appreciate Dr. Castor's involvement with the NIDDK T35 summer program and talking with medical students and providing them with research opportunities that sets them up for success in their careers. And one of her trainees is here with us today, and a graduate of the T35 program. So Dr. Castor, look forward to hearing about our research.
Thanks for that introduction, and it's always wonderful to be here with my colleagues in endocrinology. And I know I've kind of changed the subject a little bit. If you've ever been to my talks the last few years, my focus was on lupus nephritis. And I thought I would talk about IgA nephropathy because it really is kind of a hot topic in nephrology right now. A lot of it is because we finally have new treatments. So that's what I'm going to discuss today. And while we may be giving you less business because we might not be using as much high-dose corticosteroids and causing steroid-induced diabetes, hopefully you will find that our new treatments are a little bit safer and hopefully more effective in our patients. So I do have some disclosures. I do consulting for several pharmaceutical companies. I am a local PI on several industry-sponsored clinical trials, sponsored by AstraZeneca, Alexion, Chinook, and Travere. And some of the studies that I am a local PI on will be discussed in this. And I do receive speakers' fees from the following organizations. However, I promise you this talk will be unbiased, and I'm going to present what is in the literature and what we found in our studies. So the learning objectives today are fairly broad. I know I'm not speaking to a nephrology audience, so I'd like you to first have a basic understanding of IgA nephropathy and when you may consider it or consider referring to nephrology. I'd also I know this audience probably knows very well some of the limitations of systemic corticosteroid therapy in general because of all the side effects, but specifically in IgA nephropathy and why we've tried to move away from it. And then hopefully you'll walk away understanding some novel treatment pathways in IgA nephropathy, some which started in diabetic kidney disease. So it's kind of exciting to see these things go full circle. So IgA nephropathy has a pretty big disease burden. It's still considered a rare disease. It's an autoimmune kidney disease, but it is the most common primary glomerular disease in the world. Very prevalent in parts of Asia and is a leading cause of end-stage kidney disease in some countries. It is characterized by microscopic hematuria, sometimes also associated with episodic gross hematuria that presents during a respiratory or other mucosal infection. And then proteinuria. There's a broad range in how this disease presents, as well as disease progression. So there's a lot of heterogeneity, with some patients falling on the very mild, minimal microscopic hematuria that's just caught on a urinalysis with no proteinuria, normal kidney function, on the very mild spectrum. And then on the...
To do that, we need to partner with organizations.
What was the question? Oh, okay. Sorry. You can ask questions at any time, but and then on the more extreme, it can actually present as a rapid progressive glomerulonephritis or crescentic glomerulonephritis, where someone might present with rapid deterioration of kidney function and leading to end-stage kidney disease in a very short period of time. Most patients fall in the middle, meaning that, they do have progressive kidney disease over their lifetime, but it goes over decades. And we're learning more and more about this as we have more studies looking back at patient populations. It does require kidney biopsy for diagnosis. And here we have, this is actually the most recent IgA patient. I just pulled this off of Arcana Labs, who does our kidney biopsies. So here you see a glomerulus. It's a little more full. The mesangial space has more cells than you would expect. There's some mesangial proliferation. And then here on immunofluorescence, you see very prominent IgA staining. And then this is within the glomerulus. It's usually more in the mesangial space, but sometimes also around the capillaries as well. So a key point, I know back when I was a med student, which was quite some time ago, we always were taught IgA nephropathy is kind of the most benign glomerular disease. People have it and they live their normal lives, which was not really the case. People have it and then they might not progress in the 5 years that they're being followed, but over a lifetime, there's a very high risk of disease progression. So this is a study that came out of the United Kingdom. So a similar patient population that we may see here in the United States, like multi-ethnic, multiracial, and it's a retrospective cohort study called the RADAR study. So it was a national registry. Over 2,000 adults and 140 children with biopsy-proven IgA nephropathy. In order to enter the study, you did have to have some risk factors. So you had to have proteinuria of over 0.5 grams per day. So it is biased against those very benign cases where there's really no proteinuria. Or you could be enrolled if you had a GFR of less than 60. But what was really surprising is the number of patients who had a progression in CKD. So the median age at diagnosis was 45. The median age at kidney failure was 48. And 50% of patients who reached 50% of the patients in the study reached kidney failure or died. So many more patients progressed than was what previously expected. And we used to stratify IgA nephropathy by patients that have proteinuria above 1 gram a day versus those that have less than. Certainly the higher level of proteinuria, the less kidney survival that you have. So over 1.76 grams in this study, at 10 years, only the estimated kidney survival rate is only 0.15. Certainly that risk goes down with less proteinuria, but even patients with kind of modest levels of proteinuria, 0.44 to 0.88 grams a day, were experiencing kidney failure. So this kind of highlights a need for better treatments in this disease that, while rare, is the most common primary glomerular disease. So I'd like to move on to a case. I know several in the audience are clinicians. So this is a case of a patient that I saw actually back in 2020 for the first time. He presented for second opinion for IgA nephropathy. He was just diagnosed on kidney biopsy 3 months prior, but reported to me that he had had intermittent hematuria since at least 5th grade. He saw a urologist in childhood, but never a nephrologist. And we hear this story a lot, where a patient, maybe they were taking a physical for the military and were found to have hematuria. Maybe they were doing a sports physical and had hematuria. But a lot of times it goes kind of unnoticed. It's not a big deal. We don't have any formal screening of UAs like they do in some countries. So a lot of times this kind of goes unchecked for many, many years. Later and after childhood, the patient did develop high blood pressure and prediabetes, excuse me, in his 30s. But even then, it was not really looked at as a big deal that he had hematuria. And then he presented to a nephrologist when his creatinine was noticed to be elevated. Unfortunately, in the United States, the average CKD stage at which IgA patients are diagnosed is stage 3 and stage 4. So we're catching it too late because these patients don't get referred to nephrology early enough. So anytime someone has persistent microscopic hematuria, even with low-level proteinuria, they should see nephrology. The patient was diagnosed at this time with IgA nephropathy. I don't expect you guys to know the MESC score, but this is a pathology scoring system that comments on mesangial proliferation, endocapillary proliferation, segmental sclerosis, tubular interstitial fibrosis, and the presence of crescents. So he did have some mesangial proliferation, some endocapillary proliferation, and segmental segmental fibrosis, as well as some tubular interstitial fibrosis. So he already had some chronicity, which with that elevated creatinine you expect. He had been started on lisinopril, but then this outside nephrologist just put him on high-dose prednisone because that was what she was taught you did in these high-risk patients with high levels of proteinuria. So he had 3 grams. And he had been on it for 3 months without a lot of follow-up. So when I saw him, his initial labs were creatinine at 2.2. His glucose was 415. And his UPCR had improved, but at the expense of this new onset diabetes. So I called him right away, made sure he was feeling okay, instructed him to see his primary care. He was started on insulin therapy, and then I basically started a rapid prednisone taper. His creatinine stabilized, and I was able to titrate him up to maximal RAS blockade. And after tapering off prednisone, he was able to discontinue his insulin. His creatinine stabilized. It had gone back down. I think he was a little volume down at that 2.2 level. So his creatinine stabilized at 1.7, but his proteinuria started drifting up again. And I discussed whether he would want to enroll in a clinical trial, which he agreed. And he was eligible for 3 months after he discontinued the prednisone. I will follow up with this case at the end. So I think it's important to note, and this patient was pre-diabetic, but I actually have had a couple patients in the last 6 months that were diabetic, that patients with diabetes can have other glomerular diseases. They don't all have diabetic nephropathy. And I thought this was really interesting. This was a recent study out of the Cleveland Clinic called the Cleveland Clinic Kidney Biopsy Epidemiology Project. And they reviewed kidney biopsies in over 1,000 patients with a history of diabetes obtained between 2015 and 2021. Now, this is a biased group, don't get me wrong. I am not stating that most patients with suspected diabetic kidney disease have another glomerular disease, because we know that we biopsy those patients that we suspect may have something else. But it is important to note, if you don't look for it, you won't find it. So we may be under biopsying patients that have diabetes and proteinuria. So only 37% of this cohort of patients from the Cleveland Clinic had diabetic kidney disease alone on biopsy. And over 60% had non-diabetic kidney disease. Some had with a combination of diabetic kidney disease, either early changes, but the most prominent feature was the non-diabetic kidney disease. And this is what they found. So 24% had FSGS, which can be primary and secondary, and I won't get into that. Some had global glomerular sclerosis. Acute tubular necrosis was seen in a small percentage, but IgA nephropathy is up there, 8%. Some had ANCA vasculitis, and then a smaller percentage had membranous nephropathy. Interestingly, they looked at factors associated with non-diabetic kidney disease on biopsy. So not having retinopathy was definitely a factor that increased the risk of having another glomerular disease. Lower A1C levels, higher GFR, and interesting lower UPCR were associated. This study didn't look at hematuria. I was kind of surprised. I will say hematuria has been shown in large studies of patients with diabetic nephropathy. Some people say up to a quarter of patients can have microscopic hematuria. But IgA nephropathy is also very common. So in a patient with diabetes that doesn't have retinopathy, doesn't have peripheral neuropathy, that does not have other small vessel disease involvement, you may think, hey, maybe this patient has a non-diabetic glomerular disease and should potentially see nephrology. Now, we're happy to see these patients diabetic kidney disease or non-diabetic kidney disease. So anytime there's proteinuria or abnormal kidney function in a diabetic, certainly send them our way. So briefly, I'd like to talk about the pathogenesis of IgA nephropathy in 4 hits, because that's what's being discussed kind of in the literature. So this is kind of a pre-hit, is the genetic risk. We know IgA nephropathy, for the most part, is a complex genetic disease. It does cluster in some families, but most of the time it's not familial. Interesting, one of the families that it clusters in is in Eastern Kentucky, and there's a really nice write-up in the 1980s about this family in Eastern Kentucky. But for the most part, it's a complex disease that's not familial. So the first step is there's this increased production and circulating levels of galactose-deficient IgA1. So IgA1 is produced in mucosal surfaces, and this galactose-deficient IgA1 we all make. But in patients with IgA nephropathy, it gets into the circulation. So it goes outside the mucosa and into the circulation. There's increased production of this mucosal IgA1, likely triggered by some infection. So a lot of patients with IgA nephropathy will say after a pharyngeal infection, they have gross hematuria, and part of that is this increased mucosal IgA. Then you get a response to the circulating galactose-deficient IgA1, because it shouldn't be seen in circulation in high quantities. And you get antibodies of IgG and IgA to this galactose-deficient IgA1, leading to this immune complex formation. And these circulating immune complexes eventually deposit into the mesangium in the kidney. And this deposition into the kidney leads to a cascade of inflammatory events. So we know we can target any of these processes when trying to treat IgA nephropathy. So this is back in 2021. These are the KDIGO 2021 guidelines. And I say back in 2021, you're like, oh, have there been new guidelines? We're going to talk about it because in 2024, just last year, the draft guidelines were proposed and they are circulating, and there will be a new set of guidelines because that's how quickly treatment has changed. So this is 2021 guidelines. And essentially, if proteinuria was over a gram a day, despite 3 months of supportive care, and supportive care meant maximally controlling the blood pressure with RAS blockade, lifestyle modification, typically low sodium diet, and addressing cardiovascular risk. If this persisted, then you could kind of go down either of these paths. One, because we had so few treatment options, it actually took you right to consider enrollment in a clinical trial. Most clinical trials had this cutoff of eGFR greater than 30. So if the patient was not eligible for clinical trial, you would go down this path, supportive care if their GFR was less than 30, and then a toxicity risk stratification for corticosteroids, because that's all we had. I'll go into the studies that kind of led to this risk stratification. So my 2020 patient that I presented is kind of a perfect example. I guess I'm a good rule follower because the other doctor went ahead and put him on high dose steroids, but then I enrolled him in a clinical trial after he had the bad side effects from the corticosteroids. So for corticosteroids, this risk evaluation includes just looking at relative contraindications for corticosteroids. So patients with low GFRs, you're less likely to have benefit unless it's a rapid change. Diabetes, of course, obesity, latent infection, secondary disease process, peptic ulcer disease, uncontrollable psychiatric illness, or severe osteoporosis. And the patient that I saw was pre-diabetic, so that can be considered on there, and their BMI was greater than 30, which accounts for a lot of our population. So what is the history of corticosteroids in IgA nephropathy? So this is kind of a timeline of major corticosteroid trials in IgA that led to their use. And then also included on here are some of the studies that led to us to pause their use. So I think this is coming up a little bit differently because my the slides I was using were a slightly different measurement. So I'm sorry if these are coming a little less clear, but I'll go through each of these. So back in 1999, there was a POTSI protocol for IgA nephropathy, which is a combination of IV methylprednisone and oral prednisone versus RAS blockade alone. This study showed an improvement in proteinuria. They didn't really go into detail on side effects, though. And this was an Italian study. We know that population doesn't have as much prediabetes and high risk, and definitely not back in 1999 as we see now. Mano also in Italy studied prednisone with ACE inhibitor versus ACE inhibitor alone. And then more recently, there were two aspects of the testing study, and then the STOP IgAN study, which looked at maximal supportive care, which in 95% of patients included ACE or ARB therapy versus steroids. STOP IgAN also included additional immunosuppression in some patients, not all. And then testing looked at oral methylprednisolone. The big difference between these two, testing and STOP IgAN, was Testing was done in a primarily Asian population, and stop IgAN was in the European population. These are some of the older studies kind of summarizing that steroid use was favored. There was reduced risk of kidney failure with corticosteroid use. However, one of the problems with a lot of these studies is they didn't really go deep into toxicity. The Stop IgAN trial was one of the first kind of large phase 3 studies that was very well controlled, where events were noted as part of the study. And there was definitely an increased risk of infection. Well, I shouldn't say definitely, 0.07 was the p-value. Approaching increased risk of infection. Definitely increased risk of impaired glucose tolerance or diabetes. And there was an increased risk of weight gain. So not surprising, these are known steroid side effects, but it was somewhat disproportionate. And more importantly, while more patients in the immunosuppressive arm in the Stop IgA trial achieved clinical remission, there was no difference in the decrease of eGFR in both groups. And ultimately, at the end of the day, our goal is to preserve kidney function. So this was considered, a negative trial for IgA nephropathy. And back in 2015, when it was published, I remember, because I was kind of junior faculty at that time, there was this big shift, like, maybe we shouldn't be using steroids. Maybe we're hurting our patients. So there was definitely less use of steroids after this study. Now, testing similarly had a number of adverse events to the point where it was actually paused halfway through the trial. So this is a really large study, 950 adults with IgA nephropathy. At the beginning, several were excluded, then 503 were randomized. Now, these might sound like small numbers compared to diabetic trials, but when we're talking about rare diseases, 500 is actually a really good number. Unfortunately, the Data Safety Monitoring Committee early on saw an imbalance of severe adverse events between the test and control treatment groups, with the majority of these severe adverse events being related to the test medication methylprednisolone that led them to halt the trial. So essentially, there were too many patients getting severe infections that were in the methylprednisolone group. They could have just stopped, but they were eager to kind of figure out whether this treatment would have any benefit. So instead, they moved to a reduced dose methylprednisolone, and they also added PJP prophylaxis. So this is the full dose group received 0.6 to 0.8 milligrams per kilogram per day of methylprednisolone, and the reduced dose was 0.4 milligrams per kilogram per day, followed by a taper. And this is part one. Part one is the high dose. So much higher rate of serious adverse events in the methylprednisolone group. However, less patients in the methylprednisolone group reached the primary composite outcome, which was decrease in eGFR by 40%, or reaching end-stage kidney disease or death from kidney failure. So they moved on to this reduced dose regimen, and this came from a presentation a few years ago at our big conference, ASN. And you can see the number of the overall combined results show a much higher number of these severe adverse events in the methylprednisolone group. But if you separate it from the full dose versus reduced dose regimen, that was attenuated when they reduced the dose of methylprednisolone. So if you give less steroid, you have less severe infections. The benefit was still there as far as reducing the risk of developing their primary endpoint. So pros and cons for corticosteroids and IgA nephropathy. Pro, you have reduced proteinuria, and it slows the progression of CKD. A con is increased infection risk, increases insulin resistance, weight gain. And the big question at this point was, can we reduce corticosteroid risk while maintaining benefits? So the 2021 guidelines I showed you that said, okay, you should consider steroids, but consider all these things that may be a risk factor to having an adverse event from a steroid, probably led to a lot of people not utilizing them. But we know that conservative therapy alone was not enough. So what can we do? So targeted corticosteroids. So these are two trials that looked at a product called Nefecon. And Nefecon is just a targeted release form of budesonide. And it is targeted to release in the Peyer's patches to affect the IgA production in the GI tract. And you might say, why target the GI tract? Apparently, most of our IgA production, because it's in mucosal surfaces, actually comes from the GI tract, which is our largest mucosal surface. So there was this idea that instead of systemic steroids, let's target local production of this galactose-deficient IgA with the use of this targeted release budesonide. So essentially, the goal was reducing the antigen that leads to these immune complexes. So there's a phase 2 study called the Nefegan study that was successful. And then that was followed by the phase 3 study, the NefeGuard study, which I'll discuss in a little bit more detail. And essentially what you're seeing here is that targeted corticosteroids reduced the decline in eGFR in patients that received them. And the patients received the drug for 9 months, and then they had a follow-up period that lasted until 24 months. So they only received the budesonide up until this point. And you can see where the GFR actually kind of went up a little bit and came down. This is the average, where the control group just went down. And then they separated it out based on patients that were enrolled in the trial that had less than 1.5 grams versus those that had greater than 1.5 grams of proteinuria, because we know the higher the proteinuria, the higher the risk. And you can still see a benefit even for those with low-level proteinuria, although the slope is a little bit flatter, where both groups with a higher level of proteinuria have a more rapid reduction in GFR. Certainly the group that was treated still benefited. And they kind of maintained their GFR during the treatment phase and then kind of started to trend down afterwards. And I know you might ask, well, why weren't they treated longer for 9 months? It was just kind of arbitrarily chosen because they thought that was enough time to see differences. A lot of times when clinical trials are designed, they want to show enough time to see a difference. It doesn't necessarily mean that that's the ideal treatment time. And actually, my colleague, Dr. Garg, is going to be starting another study here where we're looking at longer treatment periods for this trial. Yeah. So at this point, when this study came out, corticosteroids were not, the safety was a big concern, so they were not necessarily considered standard of care. So they were not on any corticosteroids. They could not be on, they were on maximal RAS blockade. So maximal RAS blockade was considered good enough treatment at this time.
Okay, so you don't really know how that would compare with a lower dose
Yeah, so that no one's compared like the testing to like the 0.5 methylprednisolone to like the delayed release budesonide. No one's compared that. A lot of people have asked, like, how do you know? Different study populations too. Testing was primarily Asian. The NefIgArd study was mostly Europe and North America.
Well, the drug company really doesn't want to do it that way.
Yeah, no, absolutely. And this is the proteinuric response, which is interesting because it does take a little bit of time. So this drug is now FDA approved for IgA nephropathy, so it's used in clinic. And I always tell my clinic patients that are on like my chart a lot, don't be surprised if in the first couple months you're not seeing a big difference. Because it does take some time. So the big difference is seen at 6 months, and then it continues. So the UPCR continued to drop even after the treatment period. Interestingly, it starts coming up as the treatment's been off for some time. And that's been a problem with steroids too. So patients on steroids, their proteinuria does rebound, and we can't just like keep redosing them, or we could, but we're going to have lots of toxicity. So this is all treatment emergent adverse events, and then serious adverse events. So very low rate of serious adverse events, only 2%, and it was pretty similar in both. There were a little bit more adverse events in the treatment group, 87% versus 69%. And some treatment that is some of these events were expected. I know acne, weight gain, things like that were kind of expected steroid side effects. And the targeted release budesonide doesn't mean that you don't get any systemic, it's just much less. Because budesonide has a very high first pass metabolism. So the majority of it's metabolized very quickly and doesn't go systemic. All right, so what about the new studies? And I'm gonna have to go quick because this is it's taking longer than I expected, but that's okay. So I'm not gonna go into DAPA and EMPA because this audience probably knows these studies quite well. But in 2020 and 2023, the DAPA CKD and EMPA kidney trials were published and really have changed the way we think about treatment of non-diabetic kidney disease, especially non-diabetic proteinuric kidney disease. And a lot of people would say that we should now add these to RAS blockade as part of this supportive therapy group. So these were general studies that did include some IgA patients. Then I already went over NefIgArd, which looked at targeted release budesonide, and I'm going to focus on these three for the rest of the talk. So we have Protect, which is a novel medication called sparsentan. It's a DIRA, and I want to make sure you guys are familiar with it because it's a dual endothelin and angiotensin receptor antagonist. And it is FDA approved for IgA nephropathy. And you may see patients that are on this. If they are on this, they don't need additional RAS blockade. They already have RAS blockade. So we always stop their RAS blockade before starting this medicine. Then we have endothelin receptor antagonists, or ERAs. Atrasentan was studied in the ALIGN study, which we were also a site. So we're a local site for Protect and ALIGN. And atrasentan is not yet approved. They did just publish their preliminary interim data, and it will likely get preliminary approval in the next, I don't know exactly when, but soon, because it was a positive study. And then Applause looked at iptacopan, which is a complement inhibitor, and iptacopan just got kind of conditional approval based on the interim analysis back in the fall. So this delayed release budesonide, sparsentan, and iptacopan are all available for writing right now prescriptions for IgA nephropathy. So in like a 2-year period, 3-year period, we have 3 new drugs. So it's exciting. So endothelin receptor antagonists, it's an interesting pathway to target in all kidney diseases because we know that increased endothelin leads to vasoconstriction, podocyte abnormalities, proteinuria, tubular interstitial fibrosis, mesangial proliferation, and inflammation. So it is a good potential target in a lot of kidney diseases. It's not specific for IgA nephropathy. And some of the ERAs that have been studied in recent years include atrasentan, avasentan, and zibotentan. And then this dual endothelin and angiotensin receptor antagonist, or DIRA, sparsentan, which I'll talk about. And you guys might recognize atrasentan because it was studied in diabetic kidney disease before it was studied in IgA nephropathy. So this is the 2-year results of the PROTECT trial, which we were part of here at UofL. So that's exciting to be part of this, this study. And it demonstrates both a reduction in proteinuria and preservation of GFR in the patients treated with sparsentan versus irbesartan. What's really unique about this study is that it actually had a treatment in the control group. So while a lot of the other studies used maximal RAS blockade as their control, the RAS blockade could be 5 milligrams of lisinopril or 40 milligrams of lisinopril, where for this study, they were all supposed to be maximized on irbesartan. So that is part of why you see a reduction in proteinuria, even in the placebo group, because we know they all got a good dose of irbesartan. The treatment arm, the sparsentan group, like I said, had more of a proteinuric reduction. Interesting safety data. So peripheral edema is something of concern in any ERAs because it was seen as a big problem in the diabetic kidney disease studies. There wasn't a huge difference in each group. And then LFT abnormalities have been seen in other ERAs. So that was something of concern and also was not seen. And there really wasn't a difference in SAEs or serious adverse events between groups. So generally well tolerated and generally safe. Because of the class, it does come with a REMS program where patients have to get monthly LFTs. And also because of the class, pregnancy is a big concern because ERAs are known to cause to be teratogenic. So if a patient is of childbearing years and is female, they have to get monthly pregnancy tests while they're on this medication. Atrasentan, not yet approved, but probably nearing approval, is studied. This is the ALIGN study, and we're also a site in that study. And this is just an endothelin receptor antagonist. So patients are taking atrasentan in addition to whatever RAS blockade they were on. So they can be on an ACE inhibitor or they can be on an ARB, and then they're on atrasentan in addition to this. And it says versus placebo because the vast majority of patients were on RAS blockade, but they did allow, I think, up to 5% of the study participants that were intolerant of RAS blockade to be part of the study. You can see here, there was a big change in proteinuria. This is just the interim analysis. So the FDA has a new way of approving drugs for kidney disease based on proteinuric reduction, but later the company has to go back. It's a preliminary approval. To get full approval, they have to show preservation of eGFR. So this is just a preliminary results showing a 38% reduction in proteinuria. They expect that that will result in preservation of GFR, but this is just the interim analysis that's being published right now. The safety data shows SAEs are similar in atrasentan versus placebo. One concerning thing is they did show increased risk of anemia in those treated with atrasentan, and a slight increased risk of fluid retention. So we do see that. Congestive heart failure was not seen, which was a big concern because in the atrasentan studies looking at diabetic nephropathy patients, there was an increased risk of congestive heart failure. But those patients probably were in general sicker and had other comorbidities. So finally, in my last few minutes, I'd like to move to complement inhibition. So I went over some of the new kind of non-immune or more supportive care options in IgA nephropathy with the ERA, DIRA, and SGLT2 inhibitors. But this is kind of a new target for immunosuppression. And the great thing about complement inhibition is it is a steroid-sparing therapy. So we know about the hits. So these are the 4 hits. And the complement pathway isn't really implied here in this hit 3 and 4, where you get the deposition of immune complexes and you have that local inflammation and complement activation, leading to injury in the kidney. So the medicine that was evaluated and is the only complement inhibitor that is currently FDA approved for the treatment of IgA nephropathy is iptacopan. There are other studies that are underway currently looking at other alternative pathway inhibitors. So iptacopan is a factor B inhibitor. It's already an FDA approved drug for paroxysmal nocturnal hematuria. And they looked at it in IgA nephropathy patients. So in the interim analysis, they had 250 patients, and they all had to have increased proteinuria. They were treated with either iptacopan or placebo. And this is the change in 24-hour urine protein to creatinine ratio at 9 months. The study is going to go out for 2 years, and it includes 443 patients. So this is just the interim analysis to get that preliminary FDA approval. So it will be interesting to see what the final analysis shows. But it is really exciting. The other thing that was interesting about this study is because it was started a little later, they allowed both for patients to be on RAS blockade and SGLT2 inhibitors, since those are becoming kind of the more background therapy for these patients. Adverse events were similar in both groups. Serious adverse events, there were 18 versus 11 in the iptacopan versus placebo group. With any complement inhibition, the biggest concern is risk of infection, especially of encapsulated organisms. So all of these patients need to be vaccinated for meningococcal infections as well as pneumonia or pneumococcal. And that's actually part of the REMS program. So there's a REMS program for this drug. If you're prescribing it, patients have to get vaccinated. And I always put my patients on prophylaxis until they're fully vaccinated. They just changed the meningococcal protocol. So now it's like 6 months in between to get fully vaccinated. But it is recommended that they stay on prophylaxis. So I have used this on one patient actually to some success. So that's kind of exciting to have another therapy. So this is the new draft guidelines. So there's been a paradigm shift. Instead of just using corticosteroids and RAS blockade, we now have all these things under lifestyle manifestation. So one is assess the risk. So anyone with IgA nephropathy that's at risk of kidney function loss, which later in the manuscript, it says anyone with greater than 0.5 grams of proteinuria a day. So it's pretty low threshold for risk of loss because we're talking lifetime risk. So anyone at risk, you should both manage IgA nephropathy specific drivers for nephron loss. So the actual underlying pathogenesis of the disease. So think about reducing the pathogenic IgA through Nefecon or that delayed release budesonide, reducing glomerular inflammation, potentially through systemic corticosteroids. Now, because this was published in 2024 and we have even newer studies, so the complement therapies may need to be added, and we're going to have B-cell therapies coming soon. So this is getting bigger. And then you manage kind of the background generic response to IgA nephropathy-induced nephron loss. This is good chronic kidney disease care. So these things apply to a lot of patients, including patients with diabetic kidney disease. So blood pressure control, you want to reduce glomerular hyperfiltration, cardiovascular risk reduction, lifestyle modification, RAS inhibition, SGLT2 inhibitors. And now we've added sparsentan, because at the time that this was written, that was the only drug available, but I imagine it's going to also include atrasentan and other similar like ERA agents as they as more studies come out. So it's kind of exciting. So this is a follow-up. So my patient that was enrolled in the PROTECT trial. So this is a patient that had steroid-induced diabetes on high-dose steroids. So wanted to get him off of the steroids quickly, and the PROTECT trial had a 3-month period where they couldn't be on steroids. So he was enrolled, received sparsentan versus irbesartan, is now an open label follow-up, so is actually on drug. And interestingly, the people that organized the study wanted to have an additional treatment in the open label follow-up to add dapagliflozin. So he was in this study within a study where they either add dapagliflozin or they don't. And if you didn't get it for 12 weeks, you got it added later. Now the patient's on dapagliflozin in addition. And then, interestingly, he was recently started on GLP-1. And I'm not going to go there yet because it is exciting. There is some benefit in patients with diabetic kidney disease. And people are speculating that there may be benefit in patients with non-diabetic proteinuric kidney disease. The patient's creatinine remains stable. With or without obesity? With obesity, yeah, or overweight, yeah. No, not by itself, with obesity. And then, and part of that is the hyperfiltration. So anytime you have a proteinuric kidney disease, it's going to add more stress to be obese. So it's going to add more stress to the kidney. So creatinine remains stable 4 years later, and proteinuria is improved. So, so in the last 5 years, I feel like as a director of a glomerular disease clinic, I have been like all over the place, feel like a ping pong ball with therapy because it really has changed that quickly. And it's important to stay up to date. So IgA nephropathy is the most common primary glomerular disease in the world. Patients can have variable presentation, but there is a very high risk of progressive kidney disease over a lifetime. And unfortunately, in the United States, a lot of these patients come to nephrology late when they already have chronic kidney disease stage 3 or higher, because it's just not something people are looking for. In the past, the therapy consisted of RAS inhibition and high-dose corticosteroid in high-risk patients. However, treatment options have expanded. So we have both novel supportive therapies that we can add on to that RAS inhibition to help prolong kidney function, as well as novel immunosuppressive therapies. Some I didn't even get to, the whole B-cell agents. None are approved yet, so I didn't want to talk about those, but they are on the horizon. So maybe next year. And that's it with that. I want to end on time. Everyone wants to end on time. We started a few minutes late, but I will take any questions at this time. Oh, yeah, absolutely.
They don't mind with like other immunosuppressive standard drugs besides.
Yeah, so
Steroids.
like rituximab was tried because you throw rituximab on everything. So anti-CD20 does not seem to be effective, which is strange because it is an immune globulin kind of mediated disease. But interestingly, B-cell therapies targeting BAFF and APRIL, which are kind of, not B-cell depleters, but affect B-cell maturation, seem to be effective. There are a lot of phase 2 studies I didn't include in here that are very positive. It's exciting. I bet in the next 5 years we will have a BAFF APRIL agent probably available, but because of time, I didn't go into those. But yes, B-cell targeted therapies, any autoimmune disease, you think about B-cell targeted therapies. Hydroxychloroquine's been studied primarily in Asia. There are some promising results as an immune modulator, but that hasn't been studied in a larger, more diverse population. So I'm hesitant to jump to those since there seem to be regional differences. I didn't mention, but like tonsillectomy has been used in like Japan and East Asia, but hasn't been helpful here in the United States or North America or European populations. So there do seem to be some regional differences in effectiveness of certain things, but yeah, there have been CellCep's been used and been successful. Sorry, not CellCept. I should use mycophenolate. We're not supposed to use trade names. So mycophenolate's been used in Asia successfully, but hasn't been repeated in Europe or North American populations. So there's been a little bit of difference as far as whether they've been successful. And I think the KDIGO 2021, I'm trying to go back, does address some of those there that are kind of specific. So it talks about tonsillectomy in Japanese, but that's based on their studies. These are international guidelines, and mycophenolate in Chinese population, because there have been some successful studies of IgA nephropathy in the Chinese population using mycophenolate. So the short and long answer is yes, other immunosuppression has been examined over the years. It's just been inconsistent in different populations. Oh yeah. Oh yeah, they've been studied. Yeah. And the stop IgA nephropathy, the large European study, they had a cohort that was just corticosteroids and then corticosteroids plus cyclophosphamide, and that's didn't really show benefit.
These are agents.
So of these agents that I just talked about, these studies. So obviously dapagliflozin and empagliflozin are available, and they can be approved for chronic kidney disease. Budesonide is commercially available. It's only specialty pharmacy. It's got a different trade name, but it's like a targeted release budesonide. Sparsentan, same thing, specialty pharmacy only. These are not things I can send to Walgreens or CVS. Sparsentan has a REMS program as well, so not very many people are signed up and can prescribe for it. Atrasentan's not commercially available yet, but probably will go in front of the FDA in the next 6 months, since this study was just published. And then iptacopan is commercially available. Again, specialty pharmacies only, also has a REMS program for the vaccines. And to make sure patients are appropriately vaccinated or prophylaxed before they're vaccinated. So I have patients on these. I have patients on budesonide. I have patients on sparsentan. I have patients on iptacopan. We were a site in both the PROTECT and ALIGN study, and they're still in being actively followed in open label at this point, but the main part of the study is closed.
So it seems like it's a very genes.
Oh, absolutely. Well, and that's a great question, because then you have IgA vasculitis. Yeah, that I could go into whole discussions. There are a lot of secondary causes listed as well. There is a lot of heterogeneity. I do think, like a lot of autoimmune diseases, there's definitely, and there's evidence that there is genetic risk, and then it's multi-hit. There's a genetic risk, then patient may get an infection that leads to this up production and this IgA, galactose deficient IgA, and more of it gets into circulation. There have been some studies showing that family members of patients with IgA nephropathy are more likely to have these abnormal circulating IgA, but why they don't get the immune complexes, because it takes all those hits. That's why I have job security, because I chose to study autoimmune disease. Yeah. Oh, absolutely. Absolutely. And I think a lot of people are trying to target those with the most inflammatory lesions with things like complement inhibitors, right? But I didn't show this slide. I took it out because my talk was too long. Even in the APPLAUSE trial, where they're looking at iptacopan, they try to look at mesangial proliferation, endocapillary proliferation, the presence of crescents, and whether that showed any benefit in those with more inflammatory lesions. And it still showed benefit across the board. I think the only part where it crossed the line was M0 lesions were not as beneficial. So if you had no mesangial proliferation, then it may not be worth getting on an iptacopan. The caveat is, for all of these trials, the biopsy requirement is very broad. So like NefIgArd required biopsies within 10 years. So it's really hard to speculate what a biopsy meant. The APPLAUSE trial, I think it was within 5 years. But even then, you're talking about trying to correlate inflammation on a biopsy that might be more than a year old. For our lupus trials, biopsies are required in 6 months. So just to, but patients don't like biopsies, and that affects enrollment. So then studies don't want to have a biopsy requirement. But to really get to that precision medicine with IgA, I think we're going to have biopsies much closer to the time of enrollment. And most of these studies did not require that. So that's the caveat. Oh, yeah. Sorry. I needed to exit out so I could see those. But yes, I'd love to hear the online question. There's a question in the back of the room too. But sorry, I'll do that. Yeah. Oh, yeah.
How variable is that between individuals? That's sort of on the genetic side.
Oh, yeah, absolutely. So that's a great question. There have been studies showing that some complement related gene variants are associated with increased risk of IgA nephropathy. So absolutely, there is genetic risk there. And then even going back to immunofluorescence on biopsy, if you have increase, so a lot of these biopsies, you'll have C3 staining. So some people speculate that increased complement on the biopsy also is a risk factor. Again, it's hard to say whether complement on a biopsy means they'll respond better to complement therapy, but there's definitely a role in genetic risk. And I don't have the gene names right now, but there are definitely studies on complement genes and risk of IgA nephropathy. Yeah. Online? Sorry, I don't want to not answer the online person. Okay, I've got to find this. I'm sorry. I got to find how to enlarge, and I know we're over. Oh, here it is. Okay. Complement regulation, protein inhibiting complement was found to be effective in treating acute ischemia-related injury. It'll be interesting to test in IgA nephropathy. Any animal model. So there are animal models of IgA nephropathy. There aren't, I need to look because there aren't very many. And it's not an area where I've studied the animals. So, but I can try to get back to you and follow up on the animal model. But complements, I mean, it's an inflammatory cascade. So it's implicated in a lot of kidney diseases, even diabetic kidney disease, which we don't think of as inflammatory. So complement inhibitors are definitely increasing in pharma for a lot of different diseases. So we have a study here studying a complement inhibitor in lupus. It's been studied in ANCA vasculitis. So I think we're going to see broader uses of complement inhibitors in the next decade, would be my prediction, because it is implied in a lot of disease processes. But feel free to email me. But thank you so much. I'm sorry to go over, but I really appreciate you guys coming and spending your late afternoon and evening. And hopefully this was endocrine related enough. But I appreciate it. Take care.